I have the pleasure of introducing our next speakers. Dr. William Nestor is an interventional cardiologist at Methodist Physicians Clinic, and he's going to speak with us on cardiovascular mechanical support devices, particularly the Impella. And we also have Dr. Travis Rosenkratz, a cardiothoracic surgeon at Methodist Physicians Clinic, speaking to us today on ECMO.
Thanks. Yeah, that's fine. Thanks everybody for being here. I know Travis echoes this sentiment. It's really an honor to be here for Matthew to kind of continue his legacy, talking about cardiovascular technology and innovations that we have. I know he was on the forefront of a lot of that, and I was very fortunate to work with him for a little while when I started my career. Today, we're going to talk about mechanical circulatory support. We're going to go full spectrum. I'll start with the little, I guess, less invasive. Travis is a bit more invasive with what I do, but the big thing that we wanted to emphasize is kind of the team-based approach we take to all this, where both he and I and our colleagues sit back, we talk, we have meaningful conversations about each patient because everybody's different and what they need is a lot different. So mechanical circulatory support, we'll kind of start basics, bare bones, kind of build on that. Really what we're talking about is temporary use to support hearts. We initially use these as like a rescue strategy when patients were in shock, when they were, fire alarm is going off, they're really circling to the drain. That's kind of what these were first developed for. And seeing the results with that, we realized, we can kind of pivot. We can use this in a different way that can be more meaningful for patients. And it's now kind of routinely seen. Now, I know you guys have seen our numbers of utilization has gone up, and a lot of that is you've got, younger individuals that were more comfortable using these just because we had used them during training. And there's some places that use these routinely, cath labs, EP suites, obviously in the ORs. And then for a lot of the staff that's here, you've seen them up in the ICUs. So this was kind of a nice drawing of kind of all the various things. Travis is going to talk about the one there over on the top right. And I think we actually have the same animation for this. So this is good. I'm going to focus on balloon pumps quickly, Impellas, and then the Impella RP, which I drew big red arrows so that I remember what I'm supposed to talk about today also. So really, the big thing about this is we've really expanded what we can use these for and the indications. And by expanding what we can use these for, it's really driven a lot of research on what we can do with innovation and technology. The big thing, there's a lot of people here that are on this team. This team includes our nursing staff upstairs. This includes our echo techs. This includes our surgical schedulers. This includes respiratory therapy. This includes the physicians. This includes like our PAs and NPs that are here. Everybody here is helping these patients. And it's not just, it's not really what it used to be where it's like one person's driving the ship. We got a lot of different people that provide a lot of input on, what is best for these individuals. And that's kind of the big part of this. So current devices, a lot of this is just, it's a spectrum. If we need a little bit of support versus a lot of bit of support, the little bit of support would be a balloon pump where it provides a little bit extra support for the heart and kind of get you through things. The other thing we take into factor is who's the patient? A patient who's 5 feet tall and 100 pounds versus someone that's starting for the Creighton Blue Jays, very different size individual, very different size conduits that we can use. So there's a lot of factors at play. And then the biggest thing is, why are we doing this? Like, what do we need support here? What is the major driver of what's going on? Obviously, operator experience can help kind of persuade what is used in certain scenarios where certain people are a lot more comfortable with a certain device, so they're going to use it more often versus others. And then really the biggest thing is we balance goals and benefits of each device for each patient. Everybody is individual, everybody's unique. What's available and what you are comfortable with is what is going to be the best for the patient. So an intra-aortic balloon pump, I thought about bringing one in just to show people, they wouldn't let me take one and I couldn't get like the apparatus, I would inflate and everything. But these have been around for a real long time. I mean, this is like the old tried and true, the trusty dog. We like using these a lot because it's quick to put in, it's easy to put in, it's really low key, it's on, off, on, off. It inflates with helium. And so helium we use because it's an inert gas, it's got low viscosity, it goes in, it inflates the balloon real quickly, it goes out, decreases the balloon, and it increases cardiac output by about a liter a minute. So everybody sitting around here, just average is anywhere from like 4 to 6 liters per minute. Our patients that are pretty sick that Dr. Rosenkranz and I take care of, sometimes it's less than 1 liter per minute. So this balloon pump can theoretically double the amount of output they're having with their heart. And that can be the difference between, getting out of the hospital and not. And so it's a good device. It's a quick device to put in. You put it in the leg. It's a small sheath. It's like an 8.5 or 9 French sheath. So a lot of people can utilize this. And really what it does, it reduces the amount of oxygen that the heart needs. What it does is when the ventricle pumps, it collapses so that blood goes by it. And as it inflates as the ventricle rests, so it kicks blood back into the heart arteries so that the heart's a lot happier. By doing that, makes pressures better, makes the heart happier, makes us a lot happier. And we get a few less phone calls regarding the patient, but maybe a few more phone calls regarding the balloon pump, which is fine. Obviously, big contraindications. If someone's got peripheral vascular disease where they don't have an artery we can put this in, you can't do this. You can do it in the arm, you can do it in the leg. By and large, we just use the leg artery because it's a little bit bigger. It's a straight shot. We can see exactly where it is. And the big thing is aortic regurgitation. So patients that have at least moderate AI, that's a pretty big contraindication. Severe AI, we wouldn't do this because you're just going to backfill a lot of blood in the heart, and all this good you think you're doing, it's really going to backpedal what you just did. So stepping up, we're going to talk about Impellas. Abiomed was the first one to make one of these. There's a couple other products that are kind of on the cusp of getting FDA approval. And the way that I describe this for people is, I mean, it's a jet ski. I mean, it's a lot less fun than a jet ski, but it's a jet ski in principle where there's an inlet that is an impeller that spins, blood goes into that, and then it shoots it out to the rest of the heart. The four main ones, and really it's three now, is the Impella RP, which has that nice curve shape, which I'll show you why. The Impella CP, which kind of has a curve like an arm. The Impella 5.5 and the 5.0, which is what we do in conjunction together. We'll start with the CP and the 5.5 because they're basically the same device, but just different amounts of flow. And these are basically what they're known as axial or microaxial flow pumps, which work by unloading the left ventricle and reducing the end diastolic pressure, which is basically pressure in the heart. And that's the big thing that we run into trouble with, is that when hearts are either fibrillating or they're weak, the pressure builds up and they can't adequately move blood out of the heart to the rest of the body. So these pumps were designed, and it was pretty ingenious. These people are, I mean, they're a lot smarter than I am. They're sitting on a yacht somewhere in the south of France, and here we are, beautiful Bellevue University, having a conversation in the middle of winter of Omaha. And they figured out that we can put these up through the artery, go across the aortic valve, and basically support the heart with just a pump that's sitting there in their legs. What we do then with the CP is it can go up to 3.5 liters. And so I was just telling you about a balloon pump. Max is 1 liter. Really, in reality, we see about half to 0.7 liters per minute. Without revealing information, we have a gentleman who has a CP in, and he is getting 3 liters of flow as we speak right now. And like, it's working well. It's a great device, and it's helping. The 5.5 and the 5.0, as expected, they made these pretty easy, so even we know what they're doing. 5.0 provides 5 liters. 5.5 can be up to 5.5 liters. Those are bigger devices. We can't put those in through the leg. That's where we work in conjunction and do what's known as an axillary cut down. We do that as well for the CP device, just kind of depending on what a patient needs. The axillary cut down we use because people can sit up. They can be interacting. They can start doing rehab with their other arm. They can kind of progress through the hospital stay as needed. All of these now have Smart Assist. Smart Assist has been a big help for us. When I started training, they didn't have this. And so for us to look and see what was going on, you know, we were coming in, we had to look at the actual console, whereas we can actually look at this now remotely. And so when there's questions that come to us, we can say, well, you know, here's the flows, here's what the current's doing. We can look and see what's going on. The big thing that helps with that is with, you know, our staff that's on the front line, like our nurses and our techs that are there physically with the patients. They can see what the flows are, they can see what the motor currents are, and that can help them kind of manage these folks. And it really helps optimize our patients. The big thing with these is we're always looking to wean. We're always looking to get these out because it's not a long-term solution for people. The ideal position, we're looking at 3.5 centimeters, and I'm going to show you an echo of what that looks like. And that's basically, so it's sitting in the ventricle, it's got enough space so it's not causing ventricular tachycardia or VF, which is what we're trying to avoid, and the heart is happy. Obviously, really tough if they've got severe AS, because that's a really narrow area. We got to get a pretty big tube through. If they've got aortic regurgitation, it's a relative contraindication, but we still will sometimes use it if need be. And again, peripheral arterial disease. That's a big kind of the tough spot for us. Then, of course, if they got a mechanical valve, it's not going to get through that. If there's a blood clot in there, it's really not a good idea because that blood clot then is going to go on a really quick vacation somewhere you don't want it to. So this is what an Impella CP looks like on fluoro when I'm putting these in. This big long thing, that's what a pacemaker ICD lead is. But the Impella is sitting here where the aortic valve is, would be right about here where this Swan-Ganz catheter is going across. This is the inlet cage. This is a little J tip that sits here in the ventricle and doesn't cause any issues. Blood comes in this way, goes through this tube, and goes out this way to the rest of the body. Here's what it looks like on echo, where here's the aortic valve, here's the inlet cage, and we measure here to here, and that actually is spot on 3.5. And here's just kind of a cartoon representation of what we're looking at here versus, what it looks like in real life. So the Impella RP, which is basically just a shift from the CP to the right side of the heart. We run into right-sided heart failure, which had been pretty tough for us to handle because there wasn't really any good options for this besides going full on ECMO, which Travis is going to talk to you all about. And the reason being, you can have a really strong left ventricle, but if it's not getting blood because the right ventricle is doing really poorly, you're not going to, it's not going to be a fun time taking care of those people. So this is also a microaxial pump. Contrary to the Impella CP, we put this in through a vein. They've got a new one that is getting through regulation. There were some hiccups that could go in through the neck, which allows people to sit up. But right now, the one that we use, it's got to go through the vein in the leg. And so they're laying flat, but this can provide up to 3.5 liters of support on the right side of the heart. This directly improves pulmonary pressures. And that's a big thing that we run into issues with our patients is afterwards, if they've got lung disease, if the right side of their heart isn't that strong, the best effort we did for this ventricle to look really well is going to not do super hot because it's not getting enough blood there. So that's kind of where the RP comes into play. All of these systems use the same console. It's just a little plug and play. It's really easy. They made it even like foolproof for us when it's high stress. And our staff has done like a really great job with this. Everybody's gotten involved. They're a lot more comfortable with these. They've done a wonderful job with our patients. So this is what an Impella RP looks like. Remember how I showed you that curve of that device? The reason it has that is this comes up from the IVC. So the lower vein in the body comes up, goes across the right atrium, goes into the right ventricle, goes across the pulmonic valve and sits up here in the pulmonary trunk. Ideally, the folks want this to kind of curl over into the left pulmonary artery. In practice, it's not as easy as it's written on paper because people are sick. They've got a lot of tortuosity. But by and large, what you're looking at here is blood flow coming in from the vein, going out to the pulmonary arteries, and they're going to be a lot happier because they're getting blood flow back over to the left side of the heart so that they can then pump blood out. So this is actually a pretty big catheter. It's 22 French, which using my hands, it's about the size of like my index finger, which is a pretty big hole to make in a vein. We do use kind of suture closure devices there or occasionally cut downs to kind of help get that closed at the end. And where this catheter sits, you guys saw that on that x-ray, is basically down in the lower leg. It's going to get the blood that's there and send it out to the lungs, get oxygenated to go to the heart, to go to the rest of the body. Obviously, if they got mechanical valves on the right side of the heart, you're not going to get through that no matter how hard you try. And then severe, basically what you're looking at is like severe valve disease, which is kind of the thing and the topic here. Is these devices are really good, except for these very specific reasons. So complications, I can't not talk about complications. We try our best to avoid these by multidisciplinary teams, selecting the right device, having staff that's constantly monitoring this for us, but things can still happen because these are very sick people. The complications, it's really split into, is this device related or is this everything else is kind of how I like to think about it. The device related ones is obviously vascular trauma, where there's a kink, if it's caused a tear, if there's been a clot somewhere on the device, whereas the extrinsic ones are patient comorbidities, which for a majority of these people, they're pretty sick. Ways we mitigate this is keeping an eye on them. We do neuro checks, we do frequent vascular checks, and we check blood counts periodically throughout the day while these are in. So cardiovascular complications, direct cardiac injury. We can cause perforation. It's a big device that gets driven up there. Anybody that's been in the cath lab seen these in, you guys see this where it looks like a really big like Mack truck driving through a really small area. And that can unfortunately cause issues. We watch this, we do echoes during this, we look at this on fluoro to kind of mitigate those. And reduce limb ischemia, which is a big thing, because again, this is a big catheter sitting in a pretty small place. We're having our staff do vascular checks regularly. If it gets to the point where it gets critical, we can actually kind of work around that, where we do what's called a distal perfusion catheter, where we put a second catheter in, run a circuit over to it, and it feeds blood down to the leg. Hematological, as expected, this is, an Impella motor. It chews up blood cells, it chews up anything that's through there, and it's pushing it through. It can cause platelets to have issues. You can bleed, you can have anemia. And so with this, we're monitoring H&Hs, we're monitoring platelet counts, we're monitoring blood counts of therapeutic levels of anticoagulation. Infection, I can't not talk about infection. We try our best. Patients being sick, we prep these sites really, really well. And some places get prophylactic antibiotics, but that's not really a standard of care. The main reasons is, we do an aseptic technique. We don't touch anything that's not in the sterile field when we're doing things. And then obviously close monitoring with staff for this. Neurologic complications. Again, these people are sick. If we're putting a device in, that means they're not getting a lot of blood flow to places. The one that we worry about the most are the kidneys and the brain. The brain not getting blood flow, not happy. You can have anoxic brain injuries, and then putting these people back on, you go from an area where it wasn't having blood, and then all of a sudden it's like the faucet just got turned on, and they can have what's known as watershed events. And so critically monitoring neurologic status with this has been a big deal with mechanical support. And obviously, if there's microembolisms that happen, we try our best to mitigate that with heparin. So cardiogenic shock, obviously that's why we're putting these in. That's why we like using these. It helps our patients do well. Patients that come in shock that are having myocardial infarctions, they tend to not make it out of the hospital. And so these, by increasing cardiac output, really changes the tide for these patients. That still remains the most common indication is cardiogenic shock. I would say a majority of patients that are getting this, it's either because they're in it or we're preventing cardiogenic shock from occurring. So the one that I was just going to quickly talk about, because I know I talked about this last year, was just high risk PCI or protected PCI, which kind of segues into protected surgery, which we're going to talk about as kind of cohort between Travis and I. So mechanical support during PCI, we use this for patients that otherwise could not get through a procedure. And that allows us to do a full revascularization, that allows them to have less contrast, that allows them to have their ventricle completely supported, and they can get through a much bigger procedure that they otherwise would not be able to. Paradoxically, I'm going to tell you guys about a study that's going on. It's called door to unload time, where you guys have all heard of door to balloon. When the patient comes in with the STEMI, we've got X amount of minutes to get the artery open. They are now looking at, you have X amount of minutes to put an Impella in, and then you sit there and you wait, which is going to be really difficult for people like me that are like ingrained in my head, like, I got to get this open. You just sit there and you wait. You put this thing in and you sit and you wait. And interestingly, these patients have done really well. So they're talking about door to unload as a surrogate to door to balloon. So high risk, obviously, most folks know what a high-risk individual is. It's complex disease, it's medical comorbidities, it's folks that are older, it's folks that are sicker, and it's folks that we typically discuss what's known as our heart conference, which we had this morning. So just a quick picture of what an Impella-assisted PCI looks like. Again, this is the identified data. This was a patient of mine that had critical left main stenosis that you see there. Rejection fraction was, I think, 15%. They were not going to get through a surgery. They were not going to get through a routine run-of-the-mill PCI. We did an Impella assisted device here, and you can see that's the LAD at the end of this. That's a lot more blood flow. They were able to wean off this device within a day, and they walked out of the hospital, I think, 3 or 4 days later. So it's a really good device in the right patients, and obviously with the correct support staff. So just kind of showing you what happens when you're doing this. This was I stole this from somebody. This isn't mine. This is way too high tech for me looking at this. But the point of the Impella, you can look at this first angiogram. So this is showing an RCA that's got a chronic total occlusion, which makes this a high-risk individual. This is a distal left main occlusion where you see this vessel's nice and plump, then it narrows down and it looks like, I-80 during the summer when there's construction and only one car is getting through. And then it becomes Dodge again, people driving 80 miles an hour. And so when you inflate the balloon in this distal left main, what I want to look at here is you can see this pressure start tanking. And that's because the heart got ischemic. When the heart gets ischemic and there's already bad arterial disease, those patients don't do really well. And that's where the Impella comes into support, where I can have a prolonged ischemic time by inflating in a left main. And this green line on the bottom is showing this is still the blood flow that they're getting. And that's going to allow them to get through this. You take the balloon down and you see that they start recovering again. So again, without an Impella, things like this would not be possible. These patients would, not have a very long, meaningful time left. But with the ability to do interventions like this, they can do remarkably well. So it's become an integral component for pretty much any integrated cardiac surgical interventional program. We certainly use it pretty regularly here. We're using it more preoperatively and perioperatively for our very sick patients that need surgical interventions that we think are going to have a really tough time postoperatively or going to post-op cardiogenic shock. So the three main uses is managing cardiogenic shock prior to surgery, using this for high-risk individuals, and then perioperatively, postoperatively helping, when they run into circulatory compromise. So patients, obviously, we talked about this. They're really high-risk patients. These are like the sickest of the sick that need a lot of resources. They need a lot of staff kind of helping out with this. There's typically multiple medical teams seeing them, multiple nursing changes that are doing handoffs. There's a bunch of techs seeing them. There's respiratory. It goes down the list of how many people are seeing them. And the big thing is the temporary preemptive support. This can make a world of difference. That makes stuff a lot easier for everybody involved, where they're just not on like autopilot or cruise control, but we know that they're getting support from their heart. So conclusions, these were historically used for rescue therapy. We're now using these routinely. We're using these preoperatively, perioperatively, postoperatively. They're getting, more indications for use. And then obviously expanded indications require multidisciplinary teams. The big take-home point is that no one's just doing this alone. We've got a really good support staff. We've got a really good cardiovascular service line that has done a wonderful job for these people. And it's a technology that we like being able to provide, and a service we really like being able to provide to our patients. Any questions before I hand it over to ECMO wizard, Dr. Rosenkrantz?
I'm Travis. I'm one of the new heart surgeons here. I'm going to talk about ECMO. It's probably one more step up from what Dr. Nestor just touched on. ECMO is kind of a big, scary word that no one really likes to hear or talk about, but it stands for extracorporeal membrane oxygenation, and especially in Europe, they call it ECLS, extracorporeal life support. So we'll touch on that here in the next couple minutes. So what is it? So for us as heart surgeons, it's an invasive, traumatic procedure that we perform really as a last ditch effort for severe cardiorespiratory failure. So the diagram here makes it look rather simple as far as how we do it. But essentially we are putting, 24 to 28 size French cannulas is what they're called. I like to call them garden hoses through the veins in your leg or artery in your leg. It sucks the blood out of the heart, oxygenates it, and then puts it back into the body. So that's kind of the simplified version of what ECMO does. And there's different types of ECMO. There's VV ECMO, which is veno-venous ECMO, or veno-arterial ECMO, which is for patients specifically with cardiac failure. As you can see with the diagram here, most of the drainage, the venous side, the deoxygenated blood is taken from the right atrium. It comes out through the body through a pump system. It gets oxygenated and then puts back through one of the vessels in the leg, most commonly the femoral artery. This is another nice slide that I stole from the Cleveland Clinic, which they don't even do ECMO, which is kind of ironic. So again, it's kind of a simplified version of allowing the heart and lungs to just completely offload and letting the pump do all of the work. So again, this is an extracorporeal technique, meaning it goes outside the body through a pump and then back into the body for people who have cardiac or respiratory failure. VV ECMO, which is, I'm sure most of you, which maybe not want to remember COVID times, VV ECMO was employed rather frequently during COVID times with people who had good hearts but had really bad lungs. A lot of young people had VV ECMO. This allowed, these patients to recover and allow the lungs to recover after, COVID issues. So we don't use that as much. Mostly in our population, we use VA ECMO, and these were patients who have acute cardiopulmonary failure, and they need the pumps to help offload their heart and then eventually, bridge to recovery. So this is what it looks like in real life. Again, I think garden hoses isn't too far off of a description here. So the dark blood here is coming out from the IVC, from the SVC, the right atrium, the deoxygenated blood. It goes through the centrifugal pump system here that gets oxygenated and then is taken back, red blood, good blood, back to the femoral artery system. And again, this provides, like Dr. Nestor was touching on, the balloon pumps about 1 liter per minute, Impella 3 to 3.5, up to 5. VA ECMO will supply full cardiac output. It's usually 5, 6 liters per minute. it's full cardiopulmonary. So I think the most important question is who gets ECMO. It's a highly selective process. It's a resource intensive and a very invasive procedure that we do, and not everyone is a candidate for it. So that's a lot of the decision making pre and post ECMO is very important because we want to give the patients who have the highest percentage of survival to be on ECMO. So VV people, mostly respiratory failure patients, which I touched on. And the inclusion and exclusion criteria are probably the most important parts of this talk. So who gets VA ECMO? So these are patients with, again, kind of isolated cardiopulmonary failure. They need cardiac support that their own heart can't provide. So who gets it? So people who have acute MIs, a lot of these are young people. They're in cardiogenic shock, which Dr. Nesser had touched on. Their heart cannot provide enough perfusion to the end organs. So they start having kidney failure, liver failure. They're having, malperfusion to the brain. These people need help, and they need help quickly. So acute MI is, it's not as common as the rest of these here, but that is an inclusion criteria. Myocarditis, I know at my time at the university, I would say this is probably one of the most common reasons we put people on VA ECMO. These are young patients who had bad viral illnesses for whatever reason and attacked their heart. The virus, they're talking EF of 20, 15, 10%. People who have no comorbidities, those are perfect candidates for ECMO. It's a bridge to their heart recovering and then getting better or getting them onto a list for heart transplant. So myocarditis is it's a scary problem because most of the time it's in young, healthy people. Cardiomyopathy, these are for ischemic cardiomyopathy patients. You have to be careful with these because some of these patients are not ECMO candidates, but if it's a select type of cardiomyopathy, they can fall into that category of yes. Decompensated heart failure, don't see it as often, especially at Methodist. And post-cardiotomy shock, I would say, is probably the most common reason we put people on ECMO. People who have open heart surgery, they've been on bypass for many hours. Their heart is slow to wake up, so they require more support than what a balloon pump or Impella could provide. So ECMO is a nice bridge for their heart to recover post open heart surgery. The exclusion criteria, again, these are the difficult conversations we have to have with patients and their families, and that VA ECMO is a lifesaver, but it is not for everyone. Most of these patients have end stage heart failure. They are not candidates for a heart transplant or VAD, which is a ventricular assist device. Anyone over the age of 70, which is kind of sad because, again, we operate on a lot of people that are over 70. But again, we want to give the most life years out of ECMO, and people over 70 in our data shows that that's not them. Chronic organ dysfunction, people with chronic lung disease like emphysema, cirrhosis and renal failure, they are excluded from this. People who've been down a long time, CPR, where there's, low chance of survival, people don't get ECMO for that. And then these other indications here. So inclusion and exclusion is a very big decision process. And that, again, credit to our team. And, it's a multidisciplinary effort. And we have a lot of conversation behind the scenes on who gets these, invasive procedures. BV ECMO, I don't want to spend too much time on. It's, again, for most patients that are acutely, they have acute respiratory failure. In our world, it's mostly when COVID happened. Nowadays, most of the time we use VV ECMOs for lung transplants or high-risk lung surgery, or if they have tracheo airway surgery, then we'll put them on ECMO for that too. But don't want to spend too much time on that. So again, this is kind of the crux of the talk too, is who gets ECMO and how do we stratify them? Where do they go? So in general, having an ECMO facility in town here, we're very lucky in Omaha to have this. I know a lot of families and patients have benefited from having the university in town here because they are able to care for, I think, 7 to 8 ECMO patients at a time. And I was there for 2 years and, saw a lot of people come off ECMO. So it's very encouraging. They have a very specialized team, but not every hospital can do ECMO. We can put people on ECMO at Methodist, which we're very good at, but maintaining them long-term is not our specialty. And that's where the university comes in. So again, ECMO is a multidisciplinary discussion between ICU teams, cardiologists, and heart surgeons. And then, we can't send them anywhere without CT surgery blessing. They have to accept the patient. We have to talk about whether they are good candidates for it and whether or not they can be bridged to a ventricular assist device or a heart transplant. And then a perfusionist or the specialized team that runs the heart-lung machine and the ECMO machines. They're wonderful people. We have a wonderful perfusion team. They have to transport with these patients. It's not too surprising. I just want to touch on just kind of what it entails to manage these patients at the bedside. Again, it's a resource intensive, highly specialized system. It requires, minute to minute monitoring, hourly numbers, the flows, and I'll go over kind of what we monitor. Not too surprising, they're one-to-one. Repositioning these patients, these big garden hoses do fall out, which is a catastrophic event, but we always called it the 2 a.m. bath when these things would fall out, which is super sad, but it does happen. So this is just kind of the basics of what we monitor and how we assess perfusion. The pump runs like a motor. It runs by RPMs. The RPMs correlate to how many liters of flow you're getting per minute. FiO2 is how much oxygen we're giving the patient's blood through the circuit. The sweep is how we get CO2 off of the patient. So all of these numbers, we have to just be very careful with how we're managing them. We assess the flows, we adjust the flows, we adjust the FiO2, we adjust the sweep. We do, hourly labs to make sure these patients are optimized. So this is just kind of a quick little snippet of how we monitor these patients. We monitor cerebral oxygenation, which tells us are flows good enough? Does the patient need more volume? Do they need blood? So we use a cerebral oximeter for that. This is what our pumps look like. I too, again, tried to steal some ammo from Methodist. I wanted to steal some cannulas. They said no. So I wanted to give you guys a visual representation of what we actually put in. This is the arterial cannula. This brings the red blood, the good oxygenated blood back into the body. This is the venous cannula. This goes up into the right atrium, which drains blood out, sends it to the pump and then back in. And then this is what the pump looks like outside the body. I'm sure most of you have seen what the screens look like. It shows us our liters per minute, which is our cardiac output. It's dependent on how many RPMs we have. So sometimes people, we need more flow, so we need more RPMs. That's dependent on their blood viscosity, what their blood counts are. And going forward, we monitor that, again, kind of hourly with these patients. So in conclusion, again, ECMO is kind of a step up as far as cardiorespiratory support, aside from going on full cardiopulmonary bypass. It provides 5 to 6 liters of flow per minute. It's a very inclusive criteria on who gets VA ECMO, but it is life-saving. But the exclusion criteria are for real because, again, it's a very resource-intensive specialty, and we want to give it to patients who have the most life years ahead of them. ECMO requires a specialized facility, which we talked about. Again, we are lucky to have the university here in town. I think we're very skilled at what we do as far as putting them on ECMO, but long-term, these patients are best served at a tertiary care facility. And again, heart surgery, again, I'm biased. Heart surgery involvement in these patients is of utmost importance because do they need something else after ECMO? Do they need a heart transplant? Do they need a assist device? And we are usually the ones that have to make that decision. So thanks for having me. Any questions from heart surgery standpoint? No one wants to talk about ECMO. So yeah. Oh, gotta wait.
It's just really.
No, it's okay.
I know. Okay, my question is just, do you do them, Dr. Rosenkrantz, or this ECMO, like initiating them, or does like EP do them?
Yeah, so the ECMO is a surgical procedure. It's done by the heart surgeons at Methodist. It depends on the situation. If it's an emergency, we usually just do percutaneous, where we'll stick the artery and vein with a needle and then a wire, and then we'll have dilators. We'll do that at the bedside. If it's more of a planned issue in the OR, then we'll do a femoral cut down, where it's actual open surgery, where we directly visualize the vessels. But it's an open invasive surgical procedure, yeah, done by the heart surgeons. Yeah. Anyone else? All right. Thanks so much.